Hello, hello, hello. Happy tomorrow, everybody. Happy Friday. Another RLR case. Prof. Rez is on his way, and I am stunned to my core. I see somebody who I haven't seen in a long time. Tiago, welcome back to VMR, my friend. How are you?
So I'm good. I'm glad I could make it today. Good to see you, my friend.
Good to see you too. Update us. How have you been?
It's okay. I'm tired, but I'm okay. So I'm happy that I have a little bit of time now and I can watch you again, guys.
Amazing. Well, tell us how did intern year go?
It is tough.
Yeah.
Yeah, I mean, I'm good. I'm done. So
Yeah.
yeah, it's good to see new faces here as well.
Yes, a
Uh,
lot of new
so
faces.
yeah, I was an intern last year
Yeah.
and ended by June. So I couldn't. I think I was not here even once during my intern year.
Yeah.
But now I'm PGY2, so I have more time and hopefully I'll be here more.
Amazing. That would be so cool. How's Gabby doing?
She's good. She's night float, so she's sleeping.
Okay, good. Amazing. Well, it's really nice to see you. Welcome back. We have a case presenter today, a very special case presenter who went through, as more than 30 people have now, the case review committee, assisted by Bia and Shema. Shreyas, welcome.
Hi, everybody. Nice to be here on CP Solvers. I've been a great fan of the podcast and the VMR series ever since it started. I'm so excited to present for the first time here.
Amazing. It's so nice to meet you. Can you tell us a little bit about your background? Where are you calling from?
I'm a graduate from India. I'm a medical graduate from India. I'm right now in Hyderabad, which is in the southern part of India. So that's just to have I have a free time right now. I finished my internship here, and now just looking at cases to present. So here I am.
Amazing. And what would be your plan in the future? Where are you hoping to continue your training?
I'm actually applying for residency this year in the US. I'll be applying for the match this year, so that's the
Amazing.
plan for now. Yeah.
We'll be rooting for you, and I think it's a great time to pass the mic to Deborah, who will tell you a little bit
Sure.
about something related to that exact same process. Take it away, Deborah.
Okay.
Hi, everyone. Nice to see you all here. Yeah, I want to talk about that tomorrow. You're going to have a special episode for everyone that is applying this year. Like we'll have Dr. Angel Gomez Citron. He's a really nice doctor that posts a lot of good insights for everyone that is applying on Twitter and on YouTube. And he will be with us tomorrow at 1 p.m. AST. And I hope to see you all there.
Amazing. Deborah and Yaz have been working together to put on quite the show for the IMG series. So very grateful to the guys. Prof. Rez, hello. Good morning.
Good morning. Wow. I'm just looking at all these lovely faces. I had lunch with Maddie the other day. Tiago keeps teaching me about all things glucose. And Shreyas and I had a session where we chatted, and Shreyas, I'm excited to work with you on what we plan.
Sure.
Sorry for the delay.
No problem.
And to everyone else, hello. It's lovely to see all of you. Back to you, Robbie.
Prof. Rez, I feel like what you do in RLR, I'm doing VMR, where the initial 2 minutes are all about one person or the other. I'm glad we have that equilibrium. But yeah, Shreyas, we're ready to rock and roll. I know our dear Shunya is scribing today. He crushed it on Wednesday. Actually described 2 cases at the same time by Maddie. So I know Shreyas will make it a little bit easier for you today, Shunya. So take it away.
Sure. So this was a patient I actually saw 3 months back, and he was a 31-year-old male patient. He actually had a lot of distressing symptoms, and he was actually pretty bothered about it. So the chief complaint for him when I saw him is he had recurrent palpitations since 8 months. And they were getting to the point where they were happening every single day and they were interfering with his day-to-day activities. He describes these palpitations as lasting for 5 to 10 minutes each time. And on many occasions, he also has dull aching chest pain, which doesn't have any particular relation with exertion. And he also had multiple near syncopal events, although he did not have a syncopal event per se. He did actually feel like he was fainting on multiple occasions. So I think that's what we have for now, and I can give you more information as we go along.
Ravi, thank you, because I'm so excited to discuss this case. And Shreyas, if I can ask you a question, can you tell me the sequence of events? Was it palpitations, then chest pain, then near passing out? Like, what was the order? Could he actually describe the order of events?
Yes. So the palpitations were something which came first. This was something which started 8 months before I first interviewed him. And then he had 2 episodes of near syncopal events, and the chest pain was on and off. It was, I don't think there was any temporal sequence to the chest pain, but he did note that he had occasional chest pain every now and then. So it was, but his chief concern was more of palpitations and these near syncopal events, which were just getting distressing day by day. So that's what
Beautiful.
was happening with him.
Beautiful. And if everyone saw what Shreyas just did, he didn't say heart palpitations, he said palpitations. There is no such thing as liver cirrhosis. There's just cirrhosis. There's no other organ that can become cirrhotic. A skin rash doesn't exist. It's just a rash. All right, Ravi, to you. No, I'm just joking. What I'm actually going to have Ravi do, because he taught me this on a recent RLR episode, is I'm going to ask him to talk about just intermittent symptoms and like how he approaches that. But what I'm going to focus on is the sequence of events. And then, Ravi, of course, you'll layer that on into the foreground problem that we're trying to solve. But the sequence of events is critical. Like, think about this for a second. If someone is having pre-syncope, what you're trying to do is you're trying to realize, is it something that's related to the heart structurally or rhythm-wise? Is it related to the nervous system? Is it a neurogenic cause of pre-syncope? Or are you dealing with orthostatic hypotension? So what I'm trying to share here is like putting these different problems and prioritizing them. When I do that exercise, and if someone told me they had palpitations, I would go towards the palpitations. So now I'm putting the near syncope aside, and my focus is palpitations. But what about the dull chest pain? The dull chest pain, it's just not enough for me to prioritize that symptom. And it's not like it's an acute, isolated event that brought him to the ED with chest pain for me to go through our 4+2+2. So I'm actually putting the dull chest pain to the side, because it would be hard for me to explain palpitations originating from chest pain in a young patient. So the center stage for me is solving the problem of palpitations. Now, when I put palpitations on the platter to try to solve, I look at this guy's age, 31 years old. And then I think about Rebecca Berger, who said, bad luck, bad genetics, risky behavior. Bad luck has to do with like you walk out and get hit by a car, or something just, unexpected happens. Risky behavior, you always have to consider that in any patient, but specifically young patient. This includes using illicit substances, maybe partaking in, various activities that might increase your risk for sexually transmitted infections, etc. But of these, when you say young palpitations, all of a sudden genetic etiologies, believe it or not, takes the forefront, with one caveat. When you say palpitations, you're probably translating that into some rhythm disturbance or some form of arrhythmia. Now, that can be anything from most commonly, probably, it would be a supraventricular tachycardia. And this can be AV-NRT, AVRT. It could be a focal atrial tachycardia, for example. And this young person, before you land on genetic, you have to be open to the fact that how about if he's someone that's like exercising regularly, takes a lot of pre-workout supplements, caffeine? Is he doing a lot of energy drinks? So in someone like this, taking that exposure history that may predispose the heart to an abnormal rhythm is crucial. Is he using methamphetamine? Is he using cocaine that increases a sympathetic surge? So the behavior is very relevant. But after you review that and endocrine disorders, because we got Tiago here, you got to say thyroid and thyrotoxicosis. But really where I would conclude with this is some form of arrhythmia. I would look for something that may be causing the arrhythmia, but I'd be open to the possibility of a genetic etiology just with this amount of data. But I'd love to pass the mic to Robbie because I think this intermittent, what you taught me is like so powerful. And then how are you thinking about the case?
Prof. Rez, when I follow you, I feel like I'm following in bright light. I'm blinded right now. And as I slowly emerge and regain my vision, I think that the episodic is just so powerful. Because when you hear episodic, unfortunately, we're all at risk of just focusing on the positive part of the symptoms. So if you're trying to draw a plot, when somebody says, I feel palpitations and near syncope, this is happening to them. They get worse. And that's so magnetically attractive to discuss. But I think it's equally important to ask ourselves, what happens before and what happens after? Why does this event spontaneously fix itself? One. And two, what happens between events? And I think that information will be so profoundly important. And as you said, we'll have to analyze what happens between events and what is it that changes his symptom complex from between event to having the event. What changes? Is it something that he's able to identify? Like, I drink 7.5 cups of coffee and then I feel palpitations? Or is it something that he's unable to identify? And by the way, his ability to identify the trigger is only as good as our questioning to try to bring that out. So just because he's unable to identify the trigger does not mean there isn't a trigger. And this is where sharpening your tools with your history by asking the right questions. How do we know what questions to ask? Well, we have to better understand what the problem is. If he's having PVCs or bradycardia or tachycardia, or if he has a normal EKG with the palpitations, our questions are going to be very different. So I think, Prof. Rez, we need to have a perfect visual of what's happening. What's happening between episodes? What's the trigger? And why does this thing stop by itself? And I think that a lot of that is still missing, including objective data of what is happening in the episode, i.e. the EKG and the vital sign assessment. But just to paint the picture, we could be missing the fact that he is having cumulative heart failure symptoms between episodes. That's one possible presentation. The other possible presentation is he's completely normal between episodes. Those two spaces are so different. So that's where I'm at. I would summarize by saying episodic disorders gravitate your attention to only focusing on the most dramatic aspect of the patient's presentation, the acute phase of the episode. But remember to track two separate questions. What is the downslope like, i.e., what is the resolution like for the patient? And what is the inter-episode period like? Those are two questions we should be able to answer. And if we're lucky, we can answer a third one. What triggers the episode? So those are the three things I'm hopeful to answer, but open to the possibility the third one may not be answerable. So I said nothing to layer onto your actual medical thinking, Prof. Rez, but excited to chew on some more data from Shreyas.
Sure. Those are great thoughts, and a lot of interesting questions in the comments as well. Some concerns for hyperthyroidism and pheochromocytoma. And his thyroid function tests were tested on multiple occasions, and they were normal. And even for the plasma metanephrites were actually tested when we saw him, so even that was normal. But then going back to his symptoms, he told me that when he has these episodes of these pre-syncopal events, he had 2 or 3 times when he felt he was going to faint, and some of the times when he feels like he's going to pass out and he's having these pre-syncopal events, it was mostly when he was taking a hot shower. And he said that almost every time, whenever he takes hot showers, he has he feels like he's going to pass out, and he has severe proximal muscle weakness. He just feels like he's just going to sit down, and he just can't get up once he's taking these hot showers. And that was something which was very surprising. I never heard anything like that in the past. And I asked him a little more about what aggravates these symptoms of passing out, and he told me that he experiences similar symptoms whenever he eats meals. And before I met him, a week prior to my interaction with him, he actually had one of these symptoms when he was taking a hot shower. And he was taken to the ED, and they actually found that he was dehydrated and his potassium was slightly low. It was 3.1 at that time. And he was given IV fluids and potassium, and his symptoms resolved within a couple of hours after getting these fluids and potassium. I think that's a little more about his symptoms. And then we have the past medical history, and I think I can talk about that once we're done with this part. Is that okay?
I'm anticipating you're not going to have a very rich past medical history. So why don't you just give us that data now? So we
Sure.
can talk
He
about
doesn't
that.
have exactly. So he just has a past medical history of appendectomy. That's
I can
about
see your
it. Those are,
paper.
yeah,
kidding,
those are that's about
Go
it.
ahead.
And he doesn't take any medications. It's just he was actually, for these palpitations, he was prescribed by his PCP Nadolol 20 milligrams, and he said that didn't help him. And he was also given verapamil for the palpitations, and that didn't help. He just tried these two drugs, and that's about it. He doesn't take any other medications. He doesn't smoke. He doesn't drink a lot of caffeinated beverages. He actually used to, but then he cut down since he started developing these symptoms, but it didn't resolve even after cutting down.
Amazing. This is such an incredibly informative history. And I think we were able to understand one aspect, which it seems like a trigger. A trigger is that that this happens when he gets a hot shower. And we learned that the episode slowly resolves either spontaneously or with intervention with hydration in the emergency room. So maybe I can just ask you explicitly, Shreya, just one question. What is he like between episodes? Feels normal, or does he still have residual symptoms?
He does. He actually, it interferes with his life a lot. He actually stopped going to work because of these symptoms. He said it's distressing to a point where he can't work anymore.
Understood. And did you feel like he was distressed out of anxiety that he would have another episode in a vulnerable situation, or that he was constantly distressed no matter what? What was your feeling based on talking to him?
It was surprising. That's because he kind of got used to it. I think that's the best way I can describe it. That's because he had all these testing done, and actually he also saw an electrophysiologist, and he got a Holter monitored on 2 occasions, and it didn't show any arrhythmias, nothing actually, and all of his EKGs in the emergency room was also normal, and so nothing on the electrophysiological studies, and everything was normal. And there was also concern that that these episodes of weakness could possibly be because of an infarct or some sort of a transient ischemic event. He got CT scans of the head.
Maybe I don't want to interrupt you, but I feel like I don't want to cheat the process, because I know you're planning on presenting data sequentially to us, and I don't want to I feel like you're being interrogated. So I'm going to play with less data than you're giving us now, just to continue the rich exercise you're giving us. And I'm excited to hear the subsequent data about the EKG and whatnot, but I appreciate the little alley-oop you just gave us. Thank you.
Sure. Okay.
I think it's, it's a very powerful element to realize, Prof. Rez, that he seems to have this trigger when he's having hot showers. And I think the problem is, the problem with locking in on that as the trigger is that it is a relatively unusual trigger for any cardiovascular catastrophes, including almost passing out. And so part of me is wondering whether this is an incidental association he's having, but it's important in parallel to not ignore that as a possible path to as a possible hypothesis. So whenever something happens, it could be causal or it could be coincidental. And the fact that this is an unusual event should make you go down both pathways, I would say. But heat is heat is not an unheard of trigger of many events. Patients with polycythemia vera will report increasing pruritus with exposure to temperatures. Patients with multiple sclerosis will have changes in their neurological symptoms with heat exposure. But what does heat do with regards to cardiovascular symptoms? And I think that's where going back to the reason for heat and pruritus in patients with P. vera can help us a little bit. So what's the mechanism there? The mechanism there is that patients with polycythemia vera don't just have a lot of red cells. They have an increase in all myeloid cell lines, including mast cells. And it is heat-induced mast cell degranulation that results in pruritus. And that concept of heat-induced mast cell degranulation extends to extensive mast cell degranulation on the spectrum of anaphylaxis or anaphylactoid type reactions. It's interesting. There are a whole variety of triggers of mast cell activity in patients, including heat exposure, including certain foods, and notoriously alcohol. So this line of questioning would be further reinforced that we're dealing with potentially a mast cell problem if we learn that there is alcohol avoidance or alcohol intolerance. But the other mechanism of heat-induced cardiovascular symptoms is something called cholinergic urticaria, where a subset of patients, because of an increase in their body temperature, have an abnormal connection between their body temperature and the vagus nerve. And they can get essentially vasovagal syncope with either excessive exogenous heat or excessive endogenous heat. So I'm really curious what you think of it, Prof. Rez, but I'm not willing to completely lock in that this is the trigger simply because it's so unusual. And the two mechanisms that I'm aware of are, is this a mast cell mediated disease or is this a vagal nerve mediated disease process? So where is your head at?
I really love the point you make in saying that maybe it's a rare red herring, but we have to pursue the possible link in parallel. I think that's so astute. It's almost like that patient who has a travel history where you incorporate that, but you don't anchor on it and you pursue another hypothesis. I think I have nothing to add to your association with heat-related disease phenomenon. I was actually typing it up in GPT-4 and you did better than GPT-4. What other thing that grabbed my attention here is two things. One is the food association to these episodes. And the second is the potassium. And I'll be very brief here because I think this case is going to get richer. But with regard to food association, this can happen. And this can happen in a couple ways where you can get weakness or near syncope, but not so much necessarily, maybe even palpitations. One is if you have an insulinoma, that you take food and some insulin-mediated processes, and Tiago can correct me in the chat, that end up having an increased tendency to release insulin, causing you to become hypoglycemic, giving you the sensation that you're lightheaded, and giving you palpitations. I don't know the exact insulin-mediated processes that are more likely to manifest in relation to food, but what I do know is when this episode occurs, I would love a point of care glucose to test that hypothesis, because hypoglycemia is a fair game for intermittent episodes of palpitations, near syncope, and not feeling well. Fair game for sure. That goes into Rabih's EKG negative palpitation schema. With regard to the potassium 3.1 is not bad, but how odd is that for a young guy to have a K of 3.1? There is a phenomenon that is more present in Southeast Asia known as hypokalemic periodic paralysis. Now, those patients, they literally can't move, but every disease we tend to learn is on a spectrum. TTP is on a spectrum. It's not that all patients will die with TTP. No. And that disease entity that I'm describing actually happens after a large meal with increased frequency. It's related to a genetic defect that leads to a hypokalemic periodic paralysis, and thyroid hormone seems to be involved in this hypothesis. So I'm really curious. I hope we capture one of these events. It seems like the heart itself is not the main site of disease. Is there something in the blood like glucose being low, potassium being low because of thyrotoxicosis, a hypokalemic periodic paralysis? Or is Rabih's hypothesis of some kind of mast cell disorder at play here? And the last thing I want to say, Rabih, is you know that patient with dementia who has like a vulnerable state and urinary retention pushes them over into altered mental status? How about if he has an underlying cardiovascular vulnerability that the vasodilation from just heat exposure makes him vulnerable to near syncope? It doesn't seem like that's the case based on the subsequent data that Shreya has presented, but we have to be open to that bucket, not just a completely separate disease, but a vulnerable host where just exposure to the heat vasodilates and causes them to pass out. Shreyas, before I give you the mic, because this was such a rich thing, I was just curious, Rabih, anything to bounce back?
Oh, I love it. No, the glucose, the potassium, those are amazing hypotheses. Nothing. Thank you.
Sure. Thank you so much for this rich discussion. So that was actually one of the concerns, whether hypoglycemia could be driving some of his symptoms. But then his glucose was checked in the ED when he actually went in for his episode of pre-syncope, and I actually spoke to him, and it was checked on multiple occasions. His finger stick glucose was actually normal on multiple occasions. So that was one of the findings. And so the thyroid function test, I'm just going to go over the labs which we had for this patient. So the thyroid function tests were normal, and the plasma catecholamines, the metanephrine levels were also normal. And his EKGs, like I mentioned earlier, has always been a normal sinus rhythm, and occasionally he did have sinus tachycardia, but nothing too significant with that. And he also was evaluated on multiple occasions, at least 2 or 3 times by electrophysiologist, and there was no arrhythmias on those tests. For his chest pain, he also got troponin TNI on multiple occasions, and they were normal. And he also got a stress test, and the myocardial perfusion was normal during that time as well. And so these were some of the tests which he already had gotten before he came to see the cardiologist, before he came to see us. So that's, do I need to elaborate on his vitals right now, or we can do that in the next aliquot?
Yeah, maybe I think, oh, go ahead, Prof. What do you think? Yeah, I think, Shreyas, maybe you can give us that next round of data, since this
next round, okay,
is negative, yeah.
Sure. So everything is actually normal. So let me just quickly go over it. His heart rate when we saw him was 71 per minute. His blood pressure was 135/82 millimeters of mercury, and respiratory rate was 20 per minute, and SpO2 was 100. And he was in no acute distress. The cardiovascular exam was normal. There was no murmurs or no additional heart sounds. The pulmonary exam, the lungs were clear to auscultation. The abdomen was soft and non-tender. His neurological exam was also normal. There was no motor, sensory, or any focal neurological deficits. And his review of systems were all within normal limits. And he did not have any GI symptoms. He did not have any diarrhea or constipation. Everything was okay. And his extremities were warm, no rashes or no other skin lesions. And his labs were had a sodium of 139, potassium of 3.3, chloride of 109, CO2 was 22, BUN was 25, creatinine of 0.8, glucose was 100, calcium was 8.9, phosphorus was 3.3, and magnesium of 1.9. I don't have the AST, ALT, and the liver function test right with me, but I think they were normal. I think there was nothing grossly wrong with that.
Shreyas, this is fantastic. Question for you. How many more aliquots do you have before the diagnosis is revealed?
There's one more test, and that's the final diagnosis, pretty much.
Robbie, do you think this is a good time to do a breakout session?
Oh yes, Prof. Rez, I think that's awesome. Yeah, there's 40 people on this call, so we all should. Yeah, go ahead.
I actually forgot to mention there was concern whether this has pre-syncopal events or it could potentially be even syncope. Could possibly be because of something related to cardiogenic syncope, and he also had an echo that was also normal. I forgot to mention that.
Oh yeah, that's important. Thank you so much, Rez. That's really.
Yeah.
So yeah, maybe since there are 40 people on the call, if you would love for people to discuss amongst themselves for 5 minutes or so. So open out some breakout rooms. If you prefer not to, that's totally okay. Just stay in the main room and we'll just pause the recording for those on YouTube. But if you're inclined to share your thoughts with your peers, I have the breakout. I have them ready. Oh, here, there. Okay. I have them ready. So just accept and hang out for a few minutes.
All right, welcome back. I'm so proud of the CP Solvers team for figuring out this pause button on Zoom. That's like brilliant. So you don't have to edit the episode. I will share where we are, Shreyas, and I try to look into your eyes to get the diagnosis, but it's been unsuccessful so far. All I see is this really young, happy, smart individual before me. But where Robbie and I, when we discussed with AMK, Tiago, and Aisha, was that we are at a juncture where we're prioritizing an episodic disease phenomenon. And initially, with the first chief problem where Shreya said palpitations, we ran towards the heart. But subsequent to this very thorough workup, we're now saying the heart isn't actually the primary site of pathology, but something is happening outside of the heart that tends to be triggered either by a meal or hot showers. And to be frank, when you're at a point in a case where nothing is jumping out, you start to focus on values that you ordinarily wouldn't focus on. So the relative hypokalemia made us consider hypokalemic periodic paralysis, and you can have a genetic form of that that's not related to the thyroid hormone. And so we would be interested in potentially consulting someone to pursue that hypothesis. Then the other thing we thought about was related to the endocrine axis. And with regard to the endocrine axis, we talked if it was a hormonal abnormality, could it be something like ACTH or in that specific domain? And then the last thing that I think is really important, Robbie, that we mentioned is what you said, like, we're not sure if when we're actually capturing him, are we capturing him during one of these episodes? Like, yes, we have the monitor on and he's had the episodes, but what is his potassium, his glucose, like during an actual event? I know I'm neglecting some stuff, Robbie, so I'd love for you to add to that or something.
Did you just invite me to talk, Prof. Rez? Oh, of course. At your risk, my friend. Yeah, no, I'm giggling and laughing because I remembered something that happened to me last week in this ER. I had a patient with cannabinoid hyperemesis syndrome where he was in the phase of not really accepting that as a diagnosis, but he comes up to me and he says, "Hey doc, can I take a shower?" And I was like, "Hey, listen, man, you're in the emergency room. Do you think you can shower in the emergency room?" But of course, I realized that was going to fix him better than anything else. So we made some arrangements. I can't tell you, some arrangements to allow this patient to have a hot shower in this emergency room. And believe it or not, he felt great. So I was just thinking, like, you know what? If I had this patient, I would repeat those arrangements to to have the hot shower and see what happens. And I think that's the most important thing in this context. And short of that, I think we were talking about, can we get any clues that linger, that persist between episodes? And that's where I think the serum tryptase to support the mast cell hypothesis would be a very helpful test. But Prof. if I'm just being fully transparent, I'm struck by the fact that he doesn't have any rash or doesn't have any erythema. So I'm between either that this is a since Shreyas is telling us that there'll be one more test. I'm between either a mast cell issue with the serum tryptase opening up that channel, or that this person has cholinergic syncope from the heat exposure. And so the cholinergic hypothesis would be that you would assess him during an episode and you would see that he has high vagal tone. But those are the two channels that I have left. I'm curious if you had to lock in, where your head would go, and pass the mic to.
No, thank you for saying that. I think that's exactly where I would be as well. And honestly, like, this person is young and we should get to a diagnosis. I know this is a VMR and we will hopefully get to a diagnosis, but sometimes in real life, you never get to a diagnosis in such a case, but you have to keep searching and keep hunting, and eventually maybe a new problem manifests that leads you to a diagnosis. But interested to learn from Shreyas, like, not only what the final diagnosis was, but how the whole journey was for him, and how was it for the patient?
Sure. This patient, there was a very rich discussion regarding all of this mast cell phenomenon, and regarding the serum tryptase, and possibly an endocrine consult for carcinoid syndrome. This was actually some of the thoughts which were running in my head too, and even the diagnosis of hypokalemic periodic paralysis. These were some of the three things even I was thinking about. But then, like I was mentioning in the breakout room, I had an echo on this patient, and the echo was also normal. And then we had a lot of other testing with regards to CT of the head, and everything was normal. And so there was concern whether the syncope or pre-syncopal events was possibly because of whether it was something related to the heart. And that was a discussion which we had. So we had the concern for cardiogenic syncope and possibly causing some of these symptoms. And we had the tilt table testing for this patient done on 2 separate occasions. And so when he was seated, the blood pressure was 132/82. And when he stood up, it was 128/77. That didn't meet the criteria for orthostatic hypotension. This was done 2 times. But then his heart rate just shot up when he got up. It was 68 per minute when he was sitting down, and when he stood up, it was 143 per minute. And the still table testing for the blood pressure and the heart rate was repeated on 2 occasions, and he had a very similar rise in the heart rate and a minor fall in the blood pressure when this was done. And the cardiologist came to diagnosis after this test.
Oh my gosh, is this POTS?
Yes.
So I can't believe that Rabih. You know what I love about this case is that we ended up outside the cardiovascular system. And I'll never forget, and I'll give the mic back to you. I was in Baltimore at Hopkins, and we had a young patient who would just get up, feel lightheaded, like she would get anxious, palpitations, all of that. Heart rate would shoot up. And I remember they wrote in the chart, oh, this patient has POTS. And I was taking over the care of another provider. And what I associated with POTS before I met this patient was tuberculosis to the vertebra. I was like, what do you mean this patient has POTS? Nothing about this is consistent with POTS. But that's when I learned about this postural orthostatic tachycardia syndrome, which is sort of like an autonomic dysregulation that occurs. And the key to that diagnosis is the normal blood pressure. Like, you can have a low blood pressure, but oftentimes it's not low. And you see this sudden shoot up of, and it's important to be able to diagnose this, because you would never give, and it's difficult to manage, to be honest with you, but like the normal blood pressure, you might be able to give like a small dose of beta blocker, I believe. But I have to go back and look at that illness. I haven't thought about it for a while. Am I surprised by this? I am, and I'll tell you why. Because like the clues of food, maybe when we go back and learn the illness script, maybe the hot shower and food are another trigger for this phenomenon. But the most common is just basically someone gets up to move and immediately their heart rate just shoots up significantly. So this was one, not the common manifestation, at least based on my limited illness script knowledge. And then two, it was a tilt table that had to be done. It wasn't just your typical orthostatic symptoms. Robbie, what are your thoughts in terms of why was it so difficult? Why didn't we not even mention this diagnosis, Robbie?
Yeah, no, I think that there's always this assumption that when you have the vitals, that you have the orthostatic vitals, and I think the absence of that is probably why this didn't cross our mind. But I actually have a really cool story to tell you all, so I'm just going to play you a video. So watch this. This is on my phone. This person has hyperextensibility. I want to stop the video now because I want you to see the face. So this is a patient I took care of when I was an R2 in residency, and this person came in and has a very similar story to the patient that you're presenting, Shreyas. She would describe pre-syncopal symptoms in the context of hot showers and whatnot, and she was diagnosed with a mast cell condition. And the interesting leap that I had was to later learn that she also had POTS. And I learned that one of the most common identifiable causes of POTS syndrome is Ehlers-Danlos, is the joint hypermobility type of Ehlers-Danlos, which is the most common type of Ehlers-Danlos. And all of these diagnoses exist on the spectrum of mast cell mediated perturbances. It's very, very interesting. So I think, Prof. Rez, the relationship that I've come to understand in a little bit of detail, certainly more, is actually there is an extensive overlapping circle between between joint hypermobility type Ehlers-Danlos, mast cell disorders, mast cell phenotypes, and POTS. And I'd be really, really curious if this patient ever volunteered or was ever elicited in their Ehlers-Danlos review of symptoms such as thin skin or hyperflexibility or things like that, because that would be another cool connection to make and potentially label this young patient with. But yeah, I think that it goes to show you how, practically speaking, I think, Prof. Rez, it goes to show you the power of orthostatic vital signs.
I think Robbie froze. That VA, San Francisco VA, is not paying its internet bill. Hopefully he comes back. I'm not sure. I don't even want to try to finish his brilliant thought where he left it. But when he comes back, we'll see what Robbie wanted to conclude. In the meantime, Shreyas, what are your takeaways for the case before we pass it to Ayesha? Oh, Robbie's back. Robbie, please finish your thought.
Oh, Prof. Rez, this is the problem. The internet's telling me to shut up, so I will.
Where we lost you was the value of orthostatic. So pick up from there.
So that was basically it, like just how powerful the value of orthostatics is. And the growth point for me will be to remind myself and dive deeper into that overlap between mast cell, POTS, and Ehlers-Danlos. Mike, to you, Shreyas.
Sure. Yeah, that's a wonderful discussion. Professor Reza was actually asking me what I felt about this case. This was actually one of the first time I actually saw the diagnosis of POTS. It was my first patient with POTS syndrome. And just to reinforce that a simple test like a tilt table can possibly uncover a lot of diagnoses like POTS and any kind of orthostatic hypotension. And I also learned that this is a pretty distressing syndrome. Patients tend to suffer a lot. It's not just the orthostasis, it's not just the palpitations or pre-syncopal events. They actually have a lot of other symptoms like anxiety, and there's an association with irritable bowel syndrome. And some of these symptoms are just so distressing to the patient that it causes a lot of anxiousness about what's going on, causing them to lose a lot of productive hours at work. And this was actually something which I learned after talking to this patient, that POTS is something which can actually be triggered by showers. I was reading about it, and I read that patients with POTS are almost always unable to tolerate standing while taking a warm shower. I didn't know that was something which was so common with this syndrome. That's something which I learned. And I also learned that there's, because I was reading about this, once I spoke to this patient, there's a syndrome called Basquiat syndrome, which is Bayer-anemic spots, cyanosis with urticaria-like symptoms. This is an association with POTS, and it's commonly seen with them. And yeah, so that's about it. And I also learned the management of POTS when I was taking care of this patient. It's just like it happened with him, IV hydration, and just making sure he's well hydrated, and wearing some compression stockings, taking enough water, and taking enough amount of salt supplementation can possibly be some of the factors which can relieve some of his symptoms, and hopefully that works for him.
I just wanted to say, Shreyas, thank you so much for bringing this case.
Sure.
Such an important case. Yes, you deserve a round of applause, my friend.
Thank you so much.
Thank you. And you presented it eloquently. I want to make sure we give enough time for Aisha to do her thing on the mic. Really excited for her teaching points.
Hello. This was such an interesting case. I've never seen a case of POTS. Okay, thank you so much for the case, Shiraz. That was amazing. And amazing discussion as usual, Prof. Rez. I love hearing your thoughts, and Rabih, of course. Okay, so we started off with a young 31-year-old male patient that presented with recurrent episodes of palpitations, recurrent episodes being emphasis on that, and occasional dull chest pain. So when we heard about the case, it's important to consider the sequence of events that are occurring and prioritize the events that are happening. So is the palpitations more important? Is the dull chest pain more important? Prioritize the events. So in a lot of these cases, you have to consider bad luck. So a patient just kind of having poor luck, risky behavior. So any substance abuse, which could increase the chances of consequences, or genetic, such as supraventricular tachycardia. In this patient, we were also considering arrhythmia could be a big cause, because we were first initially focused on cardiogenic causes because of the palpitations and the dull chest pain. Since he's such a young age patient, we need to also consider other drugs such as methamphetamines, energy drink consumption. And when we have episodic symptoms, we have to think about three very important things. What happened before the syncope or the palpitations or the chest pain? What happened between the episodes? Was there a change in the episodes? Were there any other symptoms that occurred? And what happened after the episode? The second thing we need to consider is, was there a trigger that led to the episodes happening? So in this patient, it was hot showers and eating heavy meals, or eating in general. And the third thing was, why does the episode stop by itself? So again, what happens between the episodes? And when we think about the triggers, was it an incidental trigger, or does that contribute to the possible hypothesis? Take that into consideration as well. Narrowing down the diagnosis, we have to think about how heat can lead to the syncope. So it could be mast cell mediated, because mast cells can cause the release of histamine, cause vasodilation, kind of deterring that blood flow away from the essential organs, causing the hypotension, vasodilation. Or was it vasovagal mediated? So when we talk about vasovagal, we have to consider cholinergic urticaria, which is one of the things that we need to consider, which is due to an increase in the body temperature, and there's an abnormal connection between the temperature and the vagal nerve, which causes vasovagal syncope due to either exogenous or endogenous heat. And if we're thinking about that, assess for a increased vagal tone, or it could be food association. It could be due to an insulinoma, where food can cause a sensation of lightheadedness. Excessive food intake can cause a sensation of lightheadedness, palpitations. And for that, we need to get glucose. In this patient, glucose was normal, so that's also not another cause. This patient had a potassium level of 3.3. So another differential was hypokalemic periodic paralysis, which happens because of the insulin, which pushes the potassium into the cells after a large meal, causing the paralysis. And final diagnosis was postural tachycardia syndrome, which is also called postural orthostatic tachycardia syndrome, where the BP, the blood pressure, is very normal. However, there's a sudden increase in the heart rate. It can also be associated with Ehlers-Danlos, and the management for this patient was rehydration, compression stocking, salt-limiting foods, and just colder showers to help that vasodilation not exacerbate the symptoms. And yeah, that's the teaching point. Thank you so much for the case.
Ayesha, fantastic job. Way to organize the teaching points and deliver them in a very systematic and linear way. Thank you for that, my friend. Robbie, closing thoughts?
Yeah, this is just so cool. It really is to have Shreyas have this amazing case and the rich learning that you went through. And it's so cool to see how much you learned from this case. You know, I think you made it so clear where you were before, and you took one case and you learned so much about orthostatics, so much about the management of POTS, so much about the company it keeps. And the truth is, I think there's a whole variety of diagnoses in medicine that are still nebulous and hard to understand. And you certainly enriched my understanding of this space today. I really, really appreciate it. And I think it's just so cool that you hung out with Shema and Bia to help you feel more comfortable in the space. And I hope you inspire others to share their cases with us here. I think we're all so much better for it, but especially better for hearing the wisdom of Prof. Rez percolate through our ears. So thank you, Prof. Rez. Thank you, Shreyas. Thank you, Ayesha, for teaching points. And thank you, Shunya, for crushing the scribing 2 days in a row.
Thank you, everybody.
Good to do.